So we're going to start. Good evening, all, and welcome to Oncocritical Care Society's online academic session. Today we'll discuss about acute kidney dysfunction in patient with cancer, and it's not very uncommon. We often see acute kidney dysfunction in patient in oncology ward and in onco ICU. It may be due to drug-related toxicity, it may be due to sepsis, or it may be due to entity like tumor lysis syndrome, etc. To discuss various aspects of of acute kidney injury, today we have Dr. Yes Zaveri. He is director of critical care medicine and emergency from Regency Hospital. He is also vice president of Indian Society of Critical Care Medicine. He is also convener of Sepsis Forum. Thank you, Dr. Yes, for joining us. We have
Thank you.
Dr.
Thank you for
Manoj
having me.
Dr. Manoj Arora. He's a good friend, and we are working together for last. We know each other for last 10 years. He is working. He is working as a director in Department of Nephrology in Max. Earlier that he worked in Fortis Hospital. We have also Dr. Rajiv Gupta. He is also physician and also critical care specialist in Yashoda Hospital. To moderate this session, I invite Dr. Praveen Kaur.
Yatha.
Yatha.
Praveen Kaur, she is the head of Onco ICU in Rajiv Gandhi Cancer Institute, or also she is founder president of Onco Critical Care Society. Dr. Praveen, can you start, Dr. Praveen?
Thank you. Yeah. So, good evening, everyone. Welcome, Dr. Yash, Dr.
Thank you.
Manoj, Dr. Rajiv, Dr.
Thank
Saurabh.
you.
So, as we all know that cancer treatment, it is advancing day by day. Lot of options are available now. The days are gone then when people don't. Everybody used to say that once the patient has cancer, there are no much options available. But with increasing treatment options available, of course, the other complications and patient having these complications coming to ICU is also increasing. So today we are going to discuss very important complication, very important topic, that is acute kidney injury or renal injury in cancer patients. So to start, I'll start with Dr. Yash. So Dr. Yash, I want to know what are the possible causes of kidney dysfunction in a patient with cancer apart from drugs. Drugs we will be discussing. So apart from drugs, what are the possible causes for acute renal injury?
Thank you, Dr. Parveen. Thank you for choosing a very useful topic for us to read about and for the audience to learn about. At the onset, I like to say in oncology, ICU hope is supported by physiology, not by sentiment. And AKI or dialysis should not equate with futility. AKI is much higher in oncology ICU as compared to a general ICU. AKI incidence in a hospitalized oncology patient will be 15 to 30%, and the rates in onco ICU are even higher, could be 40 to 50% depending on severity of patients. The incidence of CKD is per se also quite high. About 15 to 20% of oncology patients will have CKD for various reasons. Dr. Aurora will correct me where I am wrong. Depending on the cancer type also, the incidence varies, like multiple myeloma, the incidence would be 15 to 20%. Solid tumors can lead to obstructive neuropathy, hematological malignancy leading to tumor lysis syndrome. Again, the incidence is high, 15 to 25%, NHL and ALL. If we go on to the causes apart from the chemotherapeutic agent, which we'll be discussing in separate entirety, we can divide it into two subsets. One are the common causes which can happen in any ICU. Other are related to the oncology pathophysiology. The common ones we'll take on later, but the specific ones we'll discuss first. First will be tumor-related causes like direct tumor infiltration, lymphoma, leukemia. Some solid tumors also can infiltrate the kidneys and the tract. Urinary tract obstruction is some of the tumors, lymphadenopathy, intra-abdominal hypertension because of some of the tumor, malignant ascites, pelvic or retroperitoneal tumors leading to obstruction and hydronephrosis. paraneoplastic syndromes, metabolic complications of various diseases and the therapies like tumor lysis syndrome, hypercalcemia of malignancy, again a common and relatively unnoticed cause of renal dysfunction, hyperviscosity syndrome. Different etiology, it could be just hyperleukocytosis, which is leading to hyperviscosity. It could be macroglobulinemia, whatever cause. We are lesser knowledgeable. Dr. Manoj will elaborate on that. And various other macroglobulinemia, multiple myeloma, entities like that. Then hematological and immunological factors, multiple myeloma related kidney disease, long chain nephropathy, light chain deposition disease, amyloidosis, some infectious complications, at times viral infections, BK virus, at times fungal infections of the kidney can lead to infarct, which can further lead to AKI or CKD also. Some of the chemotherapy drugs discussing in later part. Radiation, if patient is on radiation for whatever disease, radiation nephropathy, contrast induced nephropathy. Again, it's on. Patient could be having a baseline renal dysfunction, but a contrast given can further precipitate hypovolemia, whatever cause. Some surgical complications, renal artery dissection, renal vein or renal artery injury, ischemia during tumor surgery, nephrectomy. The second part, which is the bigger part, which are the common physiological reasons, hypovolemia, dehydration, hypotension, cardiorenal syndrome and hepatorenal syndromes could be because of the disease, could be because of some of the drugs. These are the common causes what we see. But whenever you look at the patient, always remember first thing is fluid status, stewardship of nephrotoxins, try avoiding drugs which can have a combinatorial worsening of renal dysfunction, and have a protocolized approach to AKI as for any other condition. Thank you, Dr. Kaur.
Dr. Javed,
So,
point
uh,
already. Yeah, yes. Yes, Dr. Yes, sir. Right. Yeah,
sorry,
Dr. Javed already like
carry on, carry on.
elaborated everything, all the causes of kidney dysfunction in cancer patient. If Dr. Manoj and Dr. Rajiv, they want to add something, please go ahead.
Yeah.
Dr. Manoj, you are not audible.
Please
You,
unmute, please, Dr. Manoj.
Yeah, I think most
yeah,
of the causes has been covered. We have to just divide the, apart from toxins, we have to divide into same with the pre-renal, renal, and the post-renal, which
renal
most
and
of them I
post.
have covered. So, and the renal
Yes,
specifically, we have to go for the sepsis can be another part with that. The pre-ischemia can be another part. And apart from the, we will not discuss the nephrotoxins because they are the drug related.
Yeah.
But that is
yeah,
sepsis is also very important aspect of AKI, especially related to that because they are very immunocompromised and many times they present with infections. So that also should be included. And many times glomerulonephritis, which already covered, that they can be per se drug related rather than that or infection related. Right.
yeah.
That's
So, very nicely elaborated. So, as he has already mentioned, pre-renal, renal, and post-renal. And in cancer patients, you may see retroperitoneal lymph node masses or fibromas. They will also cause that obstruction like features. So they are also very important. Malignant ascites causing abdominal compartment syndrome. So all these factors are also very important in these patients. So now I would like to ask Dr. Manoj. So in a patient who has a end stage renal disease, is there any increased risk of cancer, and how? What are the factors which can predispose these patients to the risk of cancer? Dr. Manoj, please.
right. Yeah. I think ESRD itself is a disease, a state where there is patients are very immunocompromised. There is a state of inflammation. So all these lead to more prone for the infections. Diabetic per se has been caused as an increased predisposition for cancers, but especially in ESRD on dialysis, this has been debated whether the diabetic is a cause or is a predisposing factor for these patients or not. Similarly, the cancer, most common different data and different studies have proved to be have different predisposing for the cancers, but most common are genitourinary. Then we have the liver. Then we have the colonic cancer, breast cancer. In the female, the breast, the kidney, bladder, and the breast cancer are the more common. And in males, the urinary bladder, kidney, and the liver cancer were found to be more common. But this studies has been done in a different part of the, some has been done in Taiwan, some in the US, Europe. So it depends upon your geographic prevalence as well as the what is the predisposing. The liver cancer will happen when the patient is having more chronic hepatitis like hepatitis B, C. They are very
B
common
and
in
C.
dialysis patients, ESRD patients. So they will be more prone for developing the liver cancer. Otherwise, some studies have disproved that there were more colonic cancer rather than having the genitourinary cancer. So, but these all are more prone, and it has been found that there's a double the chance of developing this cancer in the ESRD population. So they should be screened well. And similarly, undiagnosed multiple myeloma has been seen in this patient. If you go with the hematological malignancy, it is not that totally, it is not found myeloma can happen even in dialysis patient, and we have caught and we have treated also. So you have to be vigilant to what you are treating. Secondly, the patient who has chronic glomerulonephritis, they have been treated with various cyclophosphamide, MMF, steroids. They have received
Yes.
many immunosuppression. So once they reach to ESRD, they are more prone for developing malignancies, and we have to be cautious about lymphomas also, leukemias also, hematological malignancy, and the solid tumor malignancy also. So the predisposing factor will define what we are dealing with. So all these cancers are more prevalent, and we have to be vigilant for these cancers.
So any immunosuppression state can cause actually increased chance of cancer. Even in a patient
Can
who
I
has sepsis.
interrupt in between?
Yes, sir, please. Yes, sir.
Oh,
Yes,
okay.
sir.
I want to ask the CKD patients, those who are on hemodialysis, they are likely to get hepatitis B or hepatitis C, right?
Yes.
So it is
Right.
a hepatitis B or hepatitis C per se causing a hepatocellular carcinoma, or the CKD has add on to over this. If I
So CKD.
recollect my the experience, the CKD, how the CKD will increase the chances of CA. It is just a
Ha.
immunosuppressant state. Immuno, however, in last 30 years, I have yet to see patients with CKD on multiple hemodialysis, diabetic, mostly are diabetic, nephropathic, hypertensive. They are developing CA. If the CA is already associated and there is a diabetes and nephropathy, that is fine. But CKD patients on hemodialysis developing CA like hematological malignancies or lymphomas or any other sarcomas, I have not seen those patients. I would like to ask Dr.
Sir,
Manoj,
actually, they are.
what is your experience?
Sir, the important is that it's a state of inflammation. Thus, as the patient is on dialysis, there is
Right.
more and more inflammation, and their CRP levels are very high. That, and there is a more oxidative stress that has been predisposed for these cancers. Similarly, the liver cancer has been more predisposed with the hepatitis, chronic hepatitis B and chronic hepatitis C, because their own
Yes.
state of inflammation is very high. That is how they are more prone for it. And that is why I'm saying in dialysis patient, you tend to miss if you are not aware of this, that the risk of cancers are at least 1.5 to 2.4 folds more than the general population. So until unless we are aware of them, then we'll find. As is the similar case as TB is very difficult to diagnose in a ESRD patient, same is the malignancy. Until unless you suspect it and you follow that patient meticulously, you will miss that. Even myelomas are missed in the dialysis patient because you will never think that he'll develop myeloma. But patient is having letharginess, bone pain. You will think it's a PTS related or some bone related disease, parathyroid, hyperparathyroid, vitamin D, but it is not. We have caught and we have treated with the chemotherapy. Even bone marrow transplant has been done in the dialysis patient also, though it is high risk, but definitely in the myeloma patient that is also. So until unless we are vigilant, and first we have to be aware that yes, dialysis population are at increased risk. Only then we will follow in that sense.
Yes, absolutely.
So definitely they have more chance.
Okay.
And I would like to add, I think the one of this disease, that acquired kidney cystic disease per se, that can increase the risk of having renal cell carcinoma, isn't it, Dr.
Renal cell
Manoj?
carcinoma.
Yes,
Yes.
I think that's
And
right.
of
Yes, well said.
course,
Autosomal polycystic kidney disease.
yeah,
Even the
and I
acquired many of
think,
the cysts in the kidneys, they can predispose.
and if patients are taking so much of analgesics, then I think they may predispose it to this transitional cell carcinoma of bladder. There are, but I think that is again related to drug use only. It does not per se, it's because of
Yeah.
kidney disease. So now the very important thing which we actually everybody should be aware of, what all drugs are, what all chemotherapeutic drugs per se are the which can cause AKI in these patients. Doctor,
Yeah.
yeah, I would like to
Yeah,
have
there
your
is a
opinion.
long list of drugs, and before we dwell into that long list, the dictum remains whenever you see a chemotherapeutic drug and a new side effect, try to Google it out. It could be drug related, it could be cardiac dysfunction, it could be liver dysfunction, it could be QT prolongation. Try to look at the side effects of the drug. Some could be common, some could be uncommon. At the same time, you have to remember some drugs like cisplatin have a very, very high risk of nephrotoxicity. Cisplatin and the other drugs in the group carboplatin, oxyplatin, they have very high risk. How to avoid it? Again, the basics, hydration, nephrotoxin, stewardship have to be followed in all the patients. Anti-metabolite drugs such as methotrexate, especially high dose methotrexate, whatever indication we are using is again a high risk category for nephrotoxicity because of crystalluria and direct tubular injury. Alkylating agent ifosfamide, I haven't had much experience with it, but it leads to a Fanconi syndrome like picture, so we should be aware of whenever we have a patient who is on ifosfamide. Anti-tumor metabolites, antibiotics like mitomycin 3. Again, this can lead to hemolytic uremic syndrome, a related well-known side effect of mitomycin C. Various other vascular endothelial growth factor inhibitors, immune checkpoint inhibitors, they also lead to nephrotoxicity, and we should be aware of these side effects. The biggest culprits remain cisplatin, tubular necrosis, high dose methotrexate, ifosfamide, and this VEGF, vascular endothelial growth factor inhibitors. The big thing to be remembered here, whenever we have nephrotoxicity, have an overall picture. Don't only look at the drug, and stopping the drug is not going to be the holy grail. Look at the complete picture, correct all the correctable things, then only the patient can improve. At times, you have to do a balance and you have to give it a low dose. Consult your nephrologist, look at the creatinine clearance. You might have to restart that drug. Electrolytes at times will be pointing towards the etiology, like Fanconi syndrome because of ifosfamide, tumor lysis syndrome leading to AKI. So have a close look at the electrolytes, optimize hydration, optimize electrolytes, avoid NSAIDs and other drugs which are nephrotoxic, and therapeutic agents are nephrotoxic or hepatotoxic. So any organ dysfunction, we should not be just stopping all the chemotherapeutic agents, blaming them. Look at the particular drug, pinpoint the drug and the environment around the drug, try to optimize, then only stop if you don't find any other cause. Thank you,
Okay,
Dr.
okay.
Manoj and Dr. Rajiv.
Yeah, we
Can
know
I
about,
can I
we
ask a
are aware.
question?
Yes, 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 sir. Yes.
So just let me know that there had been a lot of drugs which are nephrotoxic,
Mm.
and it is most of the time it is very difficult to pinpoint that which drug is responsible for your AKI because the patient is already on multiple drugs.
Mm.
So, is there any method that you can detect that this patient can likely go into AKI?
Like
Yes, sir. There is a
risk factors, like what are risk factors of he is asking basically.
Yeah.
Any
You have
Dr.
to
Monos or Dr. Yes?
recognize whether my patient will go into, or
Okay.
is there any chances that patient
Yeah.
can go
Yeah.
into AKI?
I'll, yeah, briefly tell about it. See, advanced metastatic cancer, cachexia patient, baseline renal dysfunction, hematological malignancies, myeloma, these are very high risk candidates. Other comorbidities like septic shock we already discussed, ICU admission shock because of any other cause, existing nephrotoxins, again it will add on risk. These are the common risk factors which can be elaborated. Dr. Manoj, would you like to
So
add
yeah.
on?
I think
Yeah.
there you
Otherwise, the
there
answer. The answer to, sir, your answer is that if you are starting a patient on chemotherapy and you want to know that this patient will go into AKI or not, you can go for urinary biomarkers,
Yeah.
and they can detect the even 4 to 6 hours. They can be high if the patient is predisposed for
Hmm.
AKI. Creatinine will be very late to rise. Then there are
Mm.
certain markers which rises after cisplatin phosphate
Yeah.
within
Yes.
12 hours. So you can
Yes.
go for like Kim and Gal. They are rise even immediately after post chemotherapy. So if you want to stratify the patient, you are asking who are the patient who will be at risk of developing
Yes.
AKI
Okay.
before you can find the patient. So there are methods now, and we are into era where we should apply these biomarkers more and more, so that you can already, you will know that I won't use the NSAID in this patient because already the NGAL is high after chemotherapy.
Yes.
Or then
Yes.
these are the patients who will develop AKI. So you will stratify immediately
Hmm.
that how to reduce the risk stratification, but you will not stop the chemotherapy. If you find that patient is starting developing rise of creatinine, then you know now the AKI is set in.
Hmm.
So these are the patients where you need to be again more meticulous to stop, to reduce the dose or maintain hydration, stop it for some time, then reconsider the patient for restarting the CM chemo without NSAIDs, without other PPI or other nephrotoxins. That is how the management should be for such kind of patient. The real answer lies in these, what you are asking actually.
Yeah.
So that is
And
how
I
we can
I
go
agree,
this
Dr.
in this.
Manoj, completely
Oncology
because
is a
Are,
branch where
are we
we have to give
are
anti
are we
we have
doing
to give
NGAL?
anti-chemotherapy drug. We cannot stop the patient.
Are we doing
s-
NGAL?
NGAL, urinary markers.
yeah.
Yes, sir, NGAL
s-
kit is available. There, I'm talking of
sir,
only practical aspect which are available. There
Okay.
are many markers which are not
we,
available.
Okay.
we are coming to
Okay.
biomarkers, and one thing I want to add, because in our center high dose methotrexate is used very frequently. So what do? They start hydration preemptively and along with alkalinization of urine. So the protocol they have made for methotrexate is you start the hydration and then they give drug. I think that is the way to prevent. How much it can prevent, but normally this is the protocol in our hospital whenever they are starting this methotrexate. So, anything else you want to add, Dr. Manoj?
Yes,
No.
I want to just say that I agree,
So,
Dr. Manoj. I just agree, Dr. Manoj, because regarding the importance of biomarker in this patient, because this patient they are very frail, and creatinine may not be very high in this patient, and creatinine may not be a good marker to diagnose kidney dysfunction in this patient. So
Yeah.
biomarker would be really helpful in this patient.
yes. So the my next question is to Dr. Manoj only regarding the role of biomarkers. So what is the role of biomarkers which are available for diagnosis of AKI, or is there any specific marker for cancer patients, or is there any prognostic biomarker for kidney injury? Dr. Manoj, please. Dr. Saurabh, can you please check the chat box? Somebody
Yeah,
is
yeah. I
just
have
check it
there's
please
some
once.
question answer. We'll take the question after at the end of the session.
Yeah.
Okay, fine. Thank you.
So
Dr. Manoj,
I think
please.
okay. So if this is a question, because I have already partially answered to sir a question, because he was asking who are the patients who predisposed to AKI. What is the role of biomarker? Biomarkers which patient has not developed AKI and you want to prevent AKI, or you want to find out the subclinical AKI in a patient where you will just do something to finally prevent the AKI. That is the original thought of using biomarkers. So we have the urinary biomarkers available, because earlier we were thinking it is all research molecule.
Yeah.
We have many in research, but we will just discuss the important which is practically feasible,
Hmm.
right? Otherwise, it is an endless list, so we will not be able to reach anywhere. So I will just suggest that if you are thinking of some cancer toxins like cisplatin, methotrexate, or ifosfamide, then the NGAL increases, the kidney injury molecule that increases, because that is a marker of proximal tubule injury, and NGAL is a marker of distal nephron injury, the distal tubular injury. So the NGAL increases within 4 to 6 hours of any injury. So we can find out before any creatinine or cystatin increases. Similarly, KIN increases within 12 hours of injury before we can predict it. Then we have more markers like TIM2, and that is called TIM2, and the insulin-like growth factor BP7, binding protein 7,
Hmm.
that is available in the market as a kit of NephroCheck.
Yeah.
And what they do with a small ischemic injury, with a small ischemia to the kidney, immediately their levels increases in the urine. So this was tried in the bypass surgery, that who will develop the AKI post bypass, and then they found this is important in all ischemic, and sometimes with any kind of tubular injury you can find that increased levels, and you can predict that these are the patients where AKI will develop at the very high chances. So these are the three, four markers which are very important. Similarly, now we are talking about immune check inhibitors, where immune checkpoint inhibitors are very common. So is there any specific markers which can predict that there will be immune mediated adverse effect on the kidney later on once you start using it? So yes, that marker is also available. That is by the name of CXCL9. Their levels in the urine, they increases immediately 4 to 6 hours of using this drug. If you find that the levels have increased, that more chances that later on these are the patient who might develop
AKI.
immune mediated injury to the kidney, where we find as a nephropathy or proteinuria or a rise of creatinine, and they are all treatable. So what is the advantage of that? Advantage is that you pinpoint the patient, like sir was asking, then you stratify it, that you maintain hydration, stop all other nephrotoxins, reduce the dose of nephrotoxic drug if you want to use it,
True.
or reconsider if there's a rise of creatinine, reconsider that definitely you knew that the patient will develop nephrotoxicity. Now it has developed, even if the mild rise of creatinine, you can stop the chemotherapy which you are using, hold on, use other non-nephrotoxic drugs in the same patient, because you have to treat cancer. You cannot say that we are not treating and we will leave the patient with the disease because patient has developed nephropathy. Even with the ICI checkpoint, they say that once you have treated with the steroids, again reconsider. The chance of recurrence is still 20 to 40%, but even if it is life-saving, reconsider after some time or after giving off some gap. So these are the era which we have reached, because cancer treatment is also important, preventing kidney
Yes.
injury is also important. You have to maintain a balance, how to choose that. So I think role of biomarkers will come more and more. There's a list of biomarkers, but so many of them are in research which we will not be able to use. So this we have to, even the NAG is very important marker,
Yeah.
where anytime you have the tubular injury, you can find the urine NAG levels are increased. TNF alpha, IL-16, IL-18, sorry. IL-18 is a marker which can differentiate the pre-renal with the renal, because that is more marker of ATN. So you can differentiate. So every single molecule has some role. And I just discussed in pertaining to cancer only, because today we are discussing the cancer. We have to discuss even the sepsis. The patient you are finding that you are giving pre-renal,
Yes.
and to differentiate between them, you can use the urinary NGAL, you can use KEM. If there is some injury, these molecule will increase. It's similarly
Yes.
the TIMP, that is nephrocheck, that can also be used in septicemia or ICU setting. So
Yeah.
their kits are available. So we must, but the important is it is costly. Sometimes these biomarkers are affected by the systemic inflammation. Their results are not as accurate. So the research is going on that how much predictability value of this result, or what are the biasing factors for using biomarkers. So once we are through and we are more knowledgeable, we will definitely try to. Right now in IRICU, we are not doing any of these urinary biomarkers. So there will be a stage when the cost is less, we will be using it, and there will be better management of the patients in ICU with the AKI, or whether it is nephrotoxic, is it, drug induced or non-drug induced. Definitely, yes. That is my perspective.
Hmm.
Yes.
Thank you, Dr. Monos. For the sake of
Just
audience, can
I,
you
I, I, I
ha, ha,
I think what Dr. Manoj has highlighted and enlightened us regarding the biomarkers of AKI. So I think we should be doing some markers, at least NGAL, which is the commonest one, and which is a predictor of developing AKI. But I have yet to see a hospital where NGAL is being done. Is it because of the very, very extremely high cost? Or we are just I've seen patients, despite being giving drug which are nephrotoxic, the creatinine rises maybe after 3 or 4 days. So I think NGAL should be done to avoid all these complications, because these complications can lead to a lot of expenses and lot of intensive treatment also. Sometimes the patient becomes anuric, then you might have to do CRRT and all other supportive measures. So I would say that probably keeping a cost besides the point, that the patient safety is first, and we should do this at least NGAL, so that we can be more justified in treating our patients with drugs which are actually important for the patients, and they are nephrotoxic also.
totally agree. At least the high risk group we should be doing, if not all. And they are high
Yes.
risk. Oncology patients in the ICU are already a high risk
Yes.
group. Some of the institutes, some of the cancer centers, they are actually doing it, especially for cisplatin protocol, as Dr. Praveen also mentioned. They are doing the NGAL levels. Stem cell transplant are also using NGAL and cystatin C more commonly now. General ICUs, we are still lagging behind to an extent in using these biomarkers. We should be embracing them earlier rather than late. Dr. Parveen.
Yeah, thank you so much, Dr. Manoj. So, most of the time, whenever we are using any drugs, any antibiotics, or any drug, most of the time, drug needs to be adjusted as per or renal injury, or mostly it is the GFR calculation, which is very,
Yeah.
very important. So, I would like to ask Dr. Yash, is there any separate formula for calculating this GFR in cancer patient, or the same formula is being used?
So, Cochrane formula has many discrepancies, and most of us have been using it less and less now. This CKD epidemiology correlation, which is the EGFR, which we are using now. Apart from them, there are some oncology specific formulas which are of academic interest. We are also not used them. Jalif formula sometimes used in oncology, but again, less popular now. So the most commonly used is the EGFR, and measured GFR by radio scan also could be used in very, very high risk patient. The problem with oncology patients, they are very, very cachectic. The body mass is less, there is no muscle
Doctor,
mass.
yes, your sorry,
And
sorry to interrupt. Your voice is not clear. Like, your audio is not that good.
is it clear now?
Now it's a bit clear.
Now?
Yeah, yeah. Now okay.
Okay, probably something moved. So,
Mm.
sorry, I'll repeat it. So there are few formulas. The cockroach ball formula has its own discrepancies and it is less commonly used in the ICU practice now. Most of us have started using the CTD epidemiology correlation EGFR for years altogether now. There are some onco-specific formulas, the Jelly formula, which is again not very, very popular. Why do we need side effect calculation in oncology patients? Because of the drug dosing, because of the chemotherapy drugs, which has to be calculated based on the actual GFR. So yes, it is required, but most of the centers are still dependent on cockroach gall formula, and EGFR has come in many, many places. And most of the advanced centers, the ICUs, have been using EGFR now. The oncology specific formula has no validity and they're not still popular. Yeah.
Okay.
Anything you want to add, Dr.
Yeah.
Manoj?
Uh, yes, Doctor Manoj. Doctor,
Please.
yes.
Yeah.
Yeah.
Do you think that we like rely on only creatine and creatinine clearance while
Not
adjusting
at all.
the dose? Do you think is a very right way? Because there are many other factors that can affect
Yeah.
no drug effect. In sepsis,
Yeah.
we talk about augmented renal clearance. We hardly consider
Yeah.
whether the volume distribution of a drug, right? And even sometimes we see this drug reduction, the formula, the recommendation, they are mainly for IV drug. They are not for oral drug. But I see some,
Yeah.
they also reduce the oral drugs because the oral bioavailability may be low. Without considering oral bioavailability, we cannot reduce the drug even there is high creatinine. So Dr. Manoj will be a right person to answer this question.
Yeah.
Apart, like, do you think like
Yeah, I think
we
I
should?
think in
Yes, Dr. Manoj.
I think in ICU setting definitely we can. Yeah, am I audible?
Yeah, yeah, yeah,
Yes.
audible.
Yes.
Yeah,
Yeah, actually, I lost the connection from computer, so I'm doing from
yeah,
a
yeah.
while now.
Now you're fine.
Yeah.
So I lost the computer.
Yeah,
So
I'm
I
listening.
think yeah, ICU setting, definitely creatine is not a marker because patients are very cachexic, cirrhotic,
Mhm.
there is a fluid overload. All this due to dilution of creatine and false estimation of GFR. It is said that you should, or cystatin is also not very commonly available. We can do a cystatin C based equation,
Mhm.
but right
Mhm.
now they say go for the kinetic EGFR. That is the
Mhm.
previous creatine, then the latest creatine, then the volume of distribution. So that gives some higher
Some idea.
GFR, which is actually reported, and people are
Mhm.
using that kinetic EGFR for calculating the doses of your drugs, antibiotics. Second is you can have a 24-hour or 8 hours or 12 hours urinary creatine clearance. That is another is feasible because that is still much more better than using creatine alone. But for the sake of you're gonna ease, we use CKD EPI equation to start with. But that is how all are practicing in the ICUs. But now the era will be for the calculating kinetic GFR. That will be more determined.
More,
That they have calculated that
more
we can
accurate.
calculate the GFR with the creatine, then cystatin,
Mm.
and then with the kinetic, there was a difference of 5 to 10 ml EGFR. So your dose will change. And ICU
Mm.
is one criteria. One day it is different, second day it is different, third day it is
Yeah.
different. It is not a
Yeah.
CKD, established
Mm.
CKD
Yeah.
patient
Yeah.
in ICU. So definitely we need to have more elaborated things rather than depending on creatine only.
And we don't
So
monitor drug
GFR
levels.
also need to be a dynamically. We should be measuring it dynamically.
And we don't monitor drug
Yeah,
levels.
dynamically that is called kinetic
Right.
kinetic
Yeah.
EGFR. That is a more predictive value, and we have formulas. We don't have to remember. We have just need a creatine previous to that. Then we need a present creatine, and then we need to do know the volume of distribution, body weight. There is a strict formula, and we can use the calculator because that will help the patient
Right.
rather
Yeah.
than.
So once we have established a patient with malignancy, he has AKI, and the nephrologist has instructed us to start the renal replacement therapy. So I would like to ask Dr. Manoj, so out of the modalities available, whether it should be prolonged intermittent kidney replacement therapy or continuous kidney replacement therapy, what is the ideal modality to be used? And is there any use for high cutoff hemodialysis in malignancy patients? Dr. Manoj, please.
Right. So I will just go first. When to start dialysis? That is an important question. So we have to start with the common indications like metabolic acidosis not correcting, and there's a hyperkalemia which is not amenable to medical treatment, and there's the rise of BUN. Creatinine is not a very good criteria to choose a dialysis because creatinine is many times we have found that is a confounding factors. But BUN people say that up to one if the BUN is 108, that is a criteria that, or some people say 100, that you should start thinking of doing dialysis rather than waiting prolonged. Third important patient is anuric. It is for more than 12 hours, more than 24 hours, but then everything is rising, then definitely you should start thinking of doing dialysis. What modality to choose? If the patient is hemodynamically stable, it has been shown that whether do intermittent hemodialysis or you do SLED or CRRT, there are three factors which they found that the mortality benefit was not there with one over the other. Secondly, the kidney recovery, they found it was slightly better with the intermittent hemodialysis because the kidney perfusion is better maintained there because you give rest to the patient, right? But they all are in different aspects and different studies done. If we compare, if the patient is not hemodynamically stable, then definitely intermittent hemodialysis is out of question. We have to go for a SLED, that is a sustained low efficiency dialysis, or CRRT. So many studies have proved that mortality benefit of the both are same. Renal recovery is the same after 30 days, after 90-day mortality. Hospital stay, which was better. So they found that no, that is not a criteria. Go with the what is the predisposing factor, what is the underlying mechanism of disease. If the patient is having some kind of more risk of developing cerebral edema, like the patient is having some intracranial hemorrhage, or patient is having uh, acute liver failure, so they are the patient will develop more brain edema. So they will be benefited with the CRRT. Yeah. Second important is the patient where there's hemodynamic shifts. You are finding that the multiple inotropes are ongoing, ano or at vasopressin, the still patient is not maintaining BP, then the CRRT is definitely a choice in these patients because they have more hemodynamic stability in CRRT than going to SLED. Then suppose in a patient you want a rapid correction of something like tox patient and presented with some toxins, then hemodialysis is a better choice rather than prolonging to CRRT. So it depends for what thing in AKI setting in ICU you are doing the dialysis. In CRRT, everything is under your control because you can change the bicarbonate, you can change for the lactic acidosis, they have found every dialysis of limited benefit. But definitely, if you have to choose, that CRRT is a better modality because you can replace the bicarbonate in a better way till the patient gets correction of the underlying etiology of the lactic acidosis.
So,
So that
Doctor,
is how I will suggest.
so
Yeah.
Doctor Manoj, when you start in onco patient, do you have a sub like different consideration like in compared to non-onco patient?
Sorry. Yeah, in oncology, first we have to go for that is a primary disease, right? Secondly, are we dealing with some kind of tumor lysis syndrome which has happened because of the treatment? Then definitely it's a correctable If it is a multi-organ dysfunction because of septicemia, definitely our expectation will be lesser. So in oncology patient, important is what kind of malignancy is there. It is metastatic or it is correctable, or it has happened because of the medicine, or it is like suppose in myeloma. If the patient goes on dialysis, definitely we know dialysis dependent myeloma is treatable because once the chemotherapy will start, the dialysis he will be off dialysis after some time. So in that patient, that scenario is very important for what reason we are doing the dialysis. And if we are talking of ICU setting, that then also we need to know what are the parameters, how much we can achieve. If the primary disease is metastatic everywhere and it is we are on the palliative therapy, then we have to do a meeting with the parent unit and the parents as well as the attendants and decide together how far we should go for this patient. Otherwise, definitely if we go with the only clinical parameters for dialysis, that remains the same in ICU for the nephrology indication. But cancer patients are slightly different than the others. That is my perspective on that, and we should
Thank
give consideration to that. Yeah.
Yeah,
And
just
and
yeah,
yeah.
yeah, very nicely elaborated. So, what different we follow in our general ICU, we almost follow the same in our oncology patients also. If it is a metabolic derangement which is acute, we should not write the patient off. We should correct that metabolic derangement, whether it is AKI, whether it is some other indication for renal replacement therapy. However, if it is a terminal patient and AKI is an add-on insult to the endless list of sufferings, then we have to be little late, or probably we might not offer dialysis altogether. CRRT versus hemodialysis or SLED, as rightly pointed out, cerebral edema, hemodynamic instability, we choose CRRT. Otherwise, most of the patients will choose SLED. What I do, and I'll request Dr. Manoj to elaborate on that, wherever the turnover is high of cells like tumor lysis or ALL, whatever etiology after chemotherapy, there at times there is rebound of potassium and other metabolites. Those particular patients were a little more confident and comfortable with CRRT. Is it the routine practice? Tumor lysis and wherever the metabolic load is high and the patient is in active breakdown of cells.
Yes, definitely. CRT is a better choice in these patients because but you can continue CRT for 24 to 48 hours or
Yeah,
maybe at 96 hours. Once you have achieved your parameters, then you can switch to intermittent
yeah,
hemodialysis product, or you can switch to SLED because that will reduce the cost of the patient and you
absolutely,
will be providing the equal benefit. We
absolutely.
can choose the mixture of both the also. That initially you
Yeah,
started with CRT and after 3 days you are switching to SLED. That is also very good option for these patients.
individualized.
So, yeah.
And
Is there
I think
is
yeah,
there any
another question, Dr. Praveen, you asked about the high cutoff dialysis.
yes.
Basically, a high cutoff membrane is used. What is a high cutoff? High cutoff means normal we find that there is a high flux dialyzer and there is a protein permeable dialyzer, but their permeability is also to the tune of 20 to 25 kilodalton, where in the high cutoff there's in tune of the 65 kilodalton, which can remove the free light chain. And they have compared, and in the setting of the multiple myeloma, where the patient is needing dialysis dependency is there, definitely you can use high cutoff dialysis. It will remove the free light chain assay from the body very at a very faster rate in comparison to uh, normal dialysis. So, and they have found that the renal recovery was faster and is prolonged once you use the high cutoff dialysis membrane because your free light chain assays are they're doing injury to the kidney. And once you remove these free light chain assays faster at a rapid rate, then definitely your injury will halt. And they have found they have once you can achieve the serum free light chain assays of less than 1,000 per ml something with the that is a cutoff because till how long you will continue with the high cutoff dialysis. So you have to find the value of free light chain assay till how long you want to continue. And once you have attained that less than 1,000, it means you have achieved the target. And these their comparisons has been done in many studies and they found that it is beneficial for the patient of myelomas where they are dialysis dependent. Until the time you continue with your chemotherapy and everything, you can continue along with this high cutoff dialysis. That is how we go about.
So, I would like to ask Dr. Yash. So, once it has been decided that patient is going for renal replacement therapy, so what is the ideal thing to do? Is it early RRT or it should be
Okay.
late, or is there any trial to support that? So, what is the
Yeah.
preferred mode for this thing treatment?
As we started the discussion some time back, it depends on the physiology. It should not be dependent on the popular belief in the family or the clinician. This is a terminal illness. This is a progressive disease. So we should take the decision based on the physiology, especially metabolic derangements, which can be easily corrected. We should offer renal replacement therapy as early as possible in non-palliative care settings. In a palliative care setting, we have to take opinion of the oncologist, of the family, of the nephrologist, and the intensivist. Then we decide. And often, in the palliative care subset of oncology patients, we will probably delay it and counsel the family so that they do not go for dialysis. Otherwise, we should not for a long duration, especially for easily correctable causes, as we discussed. So, indication over intention, and the indication and the timing should be defined by the disease trajectory. How good is the patient? How is the baseline health of the patient, and various scores which we use for oncology setup, ECCO score. Those scores could be used, which defines the baseline health status of the patient. So have a shared plan with the oncologist, with the nephrologist. But being an oncology patient and an acute metabolic insult, this does not for a non-refusal of dialysis. So they should be offered dialysis as for any other patient, and they should not be withdrawn from dialysis for just being an oncology patient.
Anything you want to add, Dr. Manoj?
See, I
Sorry.
100% agree. Here we have to go with the counseling, and whatever is treatable should be treated.
Yeah.
Yeah, many times we do, and the patient has another 2 months or 1 year, then it is a achievable thing, because in a cancer patient, they know what is the expectation. Every cancer has a different graph. So everything is not palliative that we should stop. That's why I discussed first also the immune checkpoints also has to be restarted if it is life saving. Even if it has
Yes.
caused AKI and we have treated with the steroids and everything, but still you have to consider, because how the malignancy will be treated then, right? That is important. Yeah.
One more point, Dr. Praveen. Sorry. So it should be a bridge to come. It should not be bridge to nowhere. The dialysis, the patient is on CRT for days altogether. It should not become like this. And we should call the quality of life rather than quantity of days, even for any support in ICU for that matter, not only dialysis.
Correct.
Yeah.
If you see, like we have been discussing, so post bone marrow transplant patients, and especially the ones who are receiving CAR T cells, so these patients they treat very very aggressively, and you just cannot think. See, as Dr. Manoj has already mentioned, all cancers are not palliative patients, so we need to see the group of the patient. Advanced metastatic disease, of course, no heroics should be done, but sometimes still family will insist, and what I believe is if there is a correctable cause, it should be treated. Whatever life it may add to patient's life, I think we need to respect their decision as well. So that comes to my last question: how far to go in cancer patients with dialysis? Because many a times people will say, so it's a cancer patient, do not go for dialysis, don't offer them this. So what is your take on this? I would ask each one of you. Dr. Rajiv, please. You want to add something, sir?
Uh, See, one thing is the age of your patient. That is very important. What is the age of your patient? If the age of your patient is such that the life expectancy is less, then definitely one has to discuss out with the family members that this is the situation. However, it may not prolong the life expectancy or may not improve the quality of life. Then the final decisions of deferring the dialysis can be taken. This is one point. Second point, if your patient is young, and you should make all efforts until unless your patient is into a metastatic disease, and where again the life expectancy seems to be much less. In those young patients, probably yes, we should make all efforts so to have them the benefit of these dialysis and the renal replacement therapies, uh, so that the internal milieu can be corrected. And once the internal milieu has been corrected physiologically, then probably yes, you may increase the survival at least in the hospital, and for how long they will, survive after that, that cannot be said at this point of time.
Oh.
So my take is that probably yes, one has to be very judicious while taking a decision on doing a renal replacement therapies in advanced cancers or metastatic cancers, and considering the age, life expectancy, and the quality of life, because nobody takes, the into account the quality of life, which is a very important aspect. If you take into the quality of life, the age, the life expectancy, then probably yes, one can be very judicious, and the nephrologist and the intensivist can be very judicious about taking the call that this renal replacement therapies has to be continued for a longer period of time.
Dr. Saurabh, you want to add something?
Yeah, I agree with all of you. But I feel sometimes dialysis is also have palliative value. Suppose patient is terminally ill
Very good.
and he is having aneuric and having pulmonary edema. I'll definitely go for dialysis, take some ultrafiltrate, and let him live peacefully for whatever days he has. Patient having hypercalcemia, having seizures, I will do some dialysis, let him live peacefully whatever days he has. So only that he has diagnosis and his life expectancy not very long, we should not withhold dialysis, and we always decide dialysis case to case basis.
True.
And I think the most important thing which everybody has already mentioned, please speak to the primary team. They will
Yes,
definitely
definitely.
tell us, because they are the ones who are following up with the patients. So they exactly know what treatment options are available. If they feel that once the patient is over this crisis and they can offer something to the patient, then definitely yes, we should offer them.
Yeah,
And
And
but
yeah,
sorry,
yeah,
sorry, you're
yeah.
saying something.
Dr. Robin,
I
if we
believe
have some
today
time, we should take some, there's some question in the chat box.
Yeah.
Even people
Okay,
from Indonesia and all, they have joined. So
okay,
we should take the question.
yeah,
The
check.
first question regarding, she is from Frida from Solo, Indonesia. She has asked if how chemotherapy dose modification is performed in patient with decreased JFR. I think it has been already discussed, right?
Yeah.
Or anything you want to add,
No.
Dr. Monos or Dr. Yas?
Yeah. It should not be, at the same time, we should not be underdosing. So,
Yeah.
in GFR, or as Dr. Manoj mentioned, kinetic GFR should be done in the ICU, which is a dynamic environment. So, we should be measuring it every, say, 48 hours or so, so that we do not overdose or underdose the patient.
Then questions are from Denny and Solo. They wanted to know what is the most common cause of kidney dysfunction in cancer patients.
Yeah, we already elaborated on that. See, the common things are always common in our life. So, hypovolemia and the intrinsic causes of renal dysfunction are more common. Sepsis, infections, then the chemotherapy drugs, and then the structural diseases which leads to post renal dysfunction. So, these are the common things which we see in our practice. Dr.
And
Manoj?
as
Yeah.
yeah,
and
I
you
would
have
like to.
already answered that,
Yeah.
because now lot of new treatments are coming up, so definitely we need to read about it, because many
Yeah.
options therapy and these drugs have to be seen as a potential cause, so that it can be modified or discontinued along with the treatable causes, of course.
And I think a simple take-home message will be in OPD, just be cautious that whatever medicines you are using, number one, do get the KFT done if you are using some nephrotoxic drugs. Don't
Yes.
try to combine nephrotoxin drug together. If you already know your cisplatin, why there is a need to use NSAID? Give non-NSAID painkillers if they want to support that. So if small things can make you correct many of the things which will not lead to many burden to the patient. So I
Mm.
think OPD based practice you should be very aware. A simple creatinine rise itself is a pointer that something has happened to the kidney, even if the patient has even no symptoms.
Mm.
Sometimes the patient presents with the symptom, like he has hypertension, which was not there, some edema. Then again, he's finding some difficulty in urine. So you have to find what is happening, because many times the Fanconi syndrome, they all can present with some without any these symptoms. So you have to be aware first. Only then you will know and diagnose rightly.
So a supplementary question for my friend Tanmay Ghatak. What is the diagnostic accuracy of NGAL?
I think I told you that NGAL diagnostic accuracy is good, that it can differentiate, it can pick up the tissue injury very faster or the kidney injury very faster before the creatinine increases. But definitely it get affected with the uh, systemic inflammation. So that is the bias we have to found, but how much that will contribute to that. Otherwise, it is proved to be very good marker, and you can use it because we want to avoid AKI, or you can predict the risk stratification who will develop AKI. So that way it can be used. It has a good
NGAL,
predictability.
Yeah.
NGAL is
Another,
85% specific for, developing the AKI.
AKI
Yeah.
or the risk of
So,
AKI.
yeah. So it
Dr.
is a
Manoj,
85%
we
specificity.
generally classify the biomarkers as damage, stress, and I think functional biomarkers. What is the basis of that?
Sorry.
Usually we classify the biomarkers as like stress biomarkers, functional biomarkers, and damage biomarkers. What was the basis of that? Like,
Because the functional are, whenever there is a initial, they will pick up the risk for the stratification. The
functional,
damage
right?
markers,
Yeah.
when damage markers are like even the temp and the insulin like growth factor,
I
that has been
think.
proved to be as a cell arrest biomarker. That is, a cell arrest has occurred, and that will marker of damage that it is going to happen, or the injury which has happened. The functional biomarkers will be like we can use the creatinine, we can use the cystatin. They are the functional biomarker which will tell the kidney function. What is the
Yeah.
functional that is there? Similarly, the early pickup point will be the NGAL, KIM, TNF alpha, IL-18, but the damage once has occurred, it will pick up the early, and the damage marker has been proved like nephrocheck I told you. That is a damage marker which can be.
Another question from Kamalip, our friend. He wanted to know
Yeah.
about nuclear GFR
Yeah.
and GFR estimation on basis of consistency.
Yeah.
Consistency.
So this radiology scan based GFR is being used, but that is more of academic use most of the time, and we are not using it in our clinical practice. Yes, scans and isotopes have been used, technetium and others, but that is more of academic interest and not of a clinical value. But they talk about this especially in oncology setup, so we should be familiar with radionuclide based GFR.
Okay. Dr.
But
Praveen,
today the
anything?
era where we can use the combined creatinine and the cystatin GFR,
Yeah.
right? That is a more predictive
Yeah.
value. The KDIGO has promoted that rather than going for nuclear or something which is not feasible. But this is
Hmm.
quite feasible, and this GFR definitely estimates much better than the creatinine or cystatin alone. So today
Hmm.
we are converting both in the formula, and then you can calculate the GFR. That will be more better calculation.
One thing which we should remember that there is really no holy grail for diagnosis. Creatinine has come to a significant level. That is why all these biomolecules are still biomarkers. They haven't graduated to the level of investigation. So the evidence is limited with most of them, and that is what we do. As Dr. Manoj pointed out, we look at the comprehensive picture. We call it biosignature or whatever you want to call it. Look at the clinical context, look at the urine output, look at the creatinine, look at NGL or cystatin C, whatever you want,
Yes.
and then have a comprehensive look as we do it in our day-to-day practice. So there will be no 100% surety with any of the biomarkers, probably. Let's see.
Thank you.
Any other question in the chat box,
No,
Dr.
I
Saurabh?
think no, no, it's enough. That's it.
Yeah.
So I think thank you everyone. I want to thank each one of you for participating. And as we know that many treatment options are coming, so we have to deal with these complications along with the obvious complications of cancer patients. So I think it is going to be another few years. It is going to be a dedicated branch as onconephrology. What do you say, Dr. Manoj?
Yes, absolutely. We should have more conferences on that also, because it's a very
Yes.
deep topic, not a very 1 hour topic. That's it.
See,
And
And
I think
I would suggest, instead of being just discussing out the complete scenario of onco and nephro, so I would say it should be a little case based study also, that
absolutely, sir.
will that will enlighten all of us, that how this has been done, and how and what was the result of these been doing this, all
right,
these
sir.
Next time,
measurements.
I will do it.
Yeah.
So
Absolutely,
I
sir.
think
Absolutely.
In fact, there was another group where Dr. Ronco was also there. He wished to join this meeting, but he is traveling, so he will look at the recordings. So we'll share them the recordings also, sir.
Uh, because we all know him. We all know
Yeah,
studying here.
It's a
Ronco
big
study,
name.
famous Ronco
yeah.
study. I
He
think
told that he has a keen interest in
Yeah.
oncology. So that is the big thing coming up, Dr.
Yeah.
Manoj.
Yeah. All right then. Thank you so much for joining us. Thank you, Dr. Saurabh, Dr. Manoj, Dr. Yash, Dr.
Thank you.
Rajiv, and all the participants. Thank you so much.
Thank you. Thank you very
Thank
much.
you. Good night. Nice meeting you.
Okay.
Bye
Bye.
bye.
Bye bye.
Bye.
Bye. Good night.